Hello and welcome. Hello and welcome to the webinar. Your Pap smear was abnormal. Now what? I am H. McClellan, the Cervical Cancer Program Coordinator at SHARE. Before the presentation begins, I'd like to tell you a little bit about SHARE. We're a national nonprofit that supports, educates, and empowers anyone who's been diagnosed with breast or gynecologic cancers and provides outreach to the general public about signs and symptoms, because no one should have to face breast, ovarian, uterine, cervical, or metastatic breast cancer alone. For more information about upcoming webinars and support groups and our helplines, please visit our website at sharecancersupport.org. We have a few housekeeping reminders for you. All participants will be muted during the presentation. Once the speaker finishes presenting, we will begin the Q&A discussion. Feel free to ask any questions through the Q&A section at the bottom of your screen. Remember that Dr. Feldman is unable to give specific medical advice, so please keep your questions general in nature. We also have closed captioning available. You can enable this feature by clicking the live transcript button at the bottom of your screen and selecting the subtitle option. This webinar is being recorded. We will share the recording in a few weeks with all the registrants, and it will also be added to our website. Now I'd like to hand it over to today's speaker to introduce herself.
Thank you very much, and thank you for this opportunity to speak to your members. So I'm a gynecologist in Boston. I've devoted my entire career to preventing and treating patients with cervical cancer and other HPV-related diagnoses of the lower genital tract. I sit on a lot of guideline committees and work in a lot of ways throughout the world to try and prevent cervical cancer, and I'm always interested in talking to patients. And so basically, I'm going to talk about, you get a Pap test or a Pap smear and it's abnormal. What happens next? I do want to disclose that I write chapters on cervical cancer screening and colposcopy for up to date, as well as I have several grants from the National Cancer Institute to study how best to screen for and manage patients with abnormal results. This slide deck was prepared in collaboration with Kelly Welch from Team Marine. Team Marine is a not-for-profit that serves to educate patients. It's a patient advocacy group around preventing and treating cervical cancer.
Dr. Feldman, can you share your slides one more time?
Hold on a second. Are my slides coming up?
And then just in presenter mode, you can see the notes. Wonderful. Perfect. Thank you.
Okay. So as you all know, cervical cancer is a cancer that affects the cervix or opening to the uterus in women. The cancer usually affects women in their 30s and 40s, but 20% of cases actually occur in women over the age of 65. The good news about cervical cancer is it's preventable, and usually in the past it was prevented by patients having an annual Pap smear. A Pap smear is a test where your provider, your gynecologist or your primary care doctor or nurse practitioner takes a sample from the entire cervix. And if you look at the slide on the or the picture on the left on your screen, you see what we see when we look in. We see a round cervix with a central canal. That's the endocervical canal. And sometimes you can see there's a white area there. That's a lesion. But the Pap actually takes circumferential cells from the whole cervix and sends it to the lab so that the lab can tell us whether there might be abnormal cells there. If, I should say before I go on, if you have abnormal cells there, there's more testing that will have to happen. So when we talk about the prevention of cervical cancer, way before you get to the Pap test, prevention relies on a two-pronged approach. The first is vaccination before the onset of sexual activity. So vaccination needs to occur mostly among children, both boys and girls, between the ages of 9 and 12, and pretty much only works really effectively if it's given before age 15. Beyond that, vaccination can help a little bit up to age 26, and is actually not thought to have much of a benefit after age 26. So the main thing we're focused on is the screening, and that's what I was getting to. The screening is the Pap test or pap smear where those cells are taken off the cervix and sent to the lab, and the lab has to sort of guess whether or not there are abnormal cells there. So the next thing is that you need a diagnostic test like a colposcopy, and then management of those results in order to truly prevent cervical cancer. So let me explain a little bit more about screening versus what happens next. So screening is the testing that all healthy people who have a cervix and who do not have a symptom, so they're asymptomatic and have always had normal tests, they get a pap or an HPV test, and that it refers to screening, and that happens between the ages of 21 and 65 usually. However, once a patient has an abnormal test result, we no longer consider that screening. In order to prevent cervical cancer, the abnormal result needs further evaluation, that's usually a colpo, and then if there's a precancer, also known as a high-grade lesion, they need treatment, and then after that, they get more frequent testing, and the more frequent testing is known as surveillance. Patients who are immunosuppressed and cannot clear the HPV virus, or who have a history of abnormal results or cancer, will get more frequent testing. So in the past, as I mentioned, there was a pap smear, and in the past, the pap smear was repeated every year. The pap smear itself was not that great a test. It only picked up about 50% of precancers before they went on to become cancers. And so there was a need to develop better tests. So the first thing that happened is we learned that cervical cancer is caused by persistent infection with high-risk HPV virus. There are 14 high or intermediate risk HPV viruses, and 80% of people have them. Most people do not get cancer, and so the issue isn't that you have it ever, it's whether it's a persistent infection that doesn't go away. So if you test positively for more than 2 years with a high-risk HPV, then we're worried that high-risk HPV will go into the cell nucleus and cause changes at the cell level that could be detected by the pap test, which is a more improved version of the historic pap smear. So what is HPV? It's a sexually transmitted infection, which rarely causes cancer, but it can cause cancer of the cervix, vagina, vulva, anus, throat, or base of the tongue, and penis. For the most part, the cervical cancer rates in countries where there is no screening and management of abnormal results is actually very, very high. But in the United States, the screening that we do prevents you from developing cervical cancer. But as I said, it's the screening and then management of abnormal results. Vaginal, vulvar, anal, and tongue cancer are way, way, way less common. And so we usually focus on the cervix. HPV is transmitted through sexual skin-to-skin contact. The person does not have to have vaginal intercourse in order to get HPV. Women who have sex with women or same-sex relationships have the same rates of HPV as heterosexual relationships. In most cases, the HPV infection clears without you knowing you've ever had it. Now, clears is not doesn't exactly mean what you think it means. A cleared infection, it means it's inactive. It does still exist in your body and can reactivate at some point in the future, but it doesn't cause a problem when it's inactive. So when you test positive, that's when it's active. There are currently 5 FDA-approved HPV tests in the United States, but not all of those tests are approved for screening. Some of them have to be used only with a pap. Some can be used without a pap and just as a screen by themselves. When you go for cervical cancer screening, you want to ask which test you're getting and what it's covered for. So most clinicians and all patients still refer to the screening as a pap smear, but in fact, it really isn't a pap smear anymore. The pap smear was the old-fashioned, where we took the smear and put it on a slide. Now, now we're putting those cells into a vial that's getting all sorts of analysis. So we call that a pap test now. We can also, on the same vial, usually send an HPV test, which screens for 14 types of HPV. Now, the HPV is not screening for abnormal cells. It's screening for your risk for developing abnormal cells, whereas the pap test is looking for abnormal cells. So they sort of look for different things, but it turns out the HPV test is more reliable in predicting your risk. If an HPV test is done by itself, that's called primary HPV testing, but it's usually done these days in the United States at the same time as a pap. So if the HPV test is positive, which is, as I said, the most important part of the testing, then the pap is also looked at to see how badly or how abnormal the cells are. If an HPV test is negative, and assuming your PAP is either a mild abnormality or abnormal, then that HPV test is very reliable and very reassuring. So what are the possible results you could get at the time of screening? If you're being screened with PAP, then your possible results are that it's normal, that you have atypical cells of undetermined significance. What that means is the person looking at the slide thinks there's something not quite right about the cells, but they're not really sure if it's a precancer or not, needs more evaluation. Low grade is the person looking at the cells thinks this is more like a wart or condyloma, not a precancer. Again, still needs a colposcopy and biopsy. High grade HSIL is high grade, is a precancer. Adenocarcinoma in situ AIS is a precancer, and cancer, of course, is cancer. So those are the different sorts of results that can come back on a PAP. The HPV test is going to generally tell you something slightly different. It's going to tell you if you have an active infection with one of the HPV types that have ever been associated with cervical cancer, although, as I mentioned, most of them are very rarely associated with cervical cancer. Sometimes your provider will ask to find out what exact type you have, and specifically if you have HPV 16 or 18/45, which are the most aggressive types of HPV. And if you have those, your evaluation will be more prompt and more aggressive. So what does it mean if your test is positive? So first of all, it's not a reason to panic. Most people who haven't been vaccinated, so that might be most people starting, let's say, in their mid to late 30s and on, have not been vaccinated before the onset of sexual activity, and 80% of those people will test positive at some point in their life. Most of these infections clear and do not cause any precancerous changes. The positive test means the infection is active, and that means it's in the cell nucleus, and if it continues to be active, it can transform those cells into precancers and eventually cancers. A negative test does not mean you've never had HPV, but it means that it's not active. And when it's not active, your risk of developing cancer, precancer is lower. It's important to note that you can be infectious even when you are HPV negative. So people are pretty much always infectious with HPV. Anytime you have a new sexual partner, you have to sort of assume that you give it and you receive the HPV or maybe a different HPV because it's so easily transmitted. Some patients, especially older patients, will have dormant infections that reactivate. Does not necessarily mean that anybody's had a new sexual exposure. And as I mentioned, HPV 16, 18 are more aggressive than the other two and are going to be managed more aggressively. So, a lot of patients will ask, what about my partner? What do I tell my partner? Well, the first thing is I want to point out, you never know who you got this from or who gave it to whom, because it's so common that pretty much you have to assume that every partner you have has had it. I always tell people that most partners, specifically if they're male partners, are not going to have any issues with HPV. And so, and most women don't know they have it either. So you don't necessarily have to tell people, because it's not like every person is going to have any in fact, most people are not going to have any consequences. But if you decide that you want to share this with your partner, you have to make sure you are clear that most people have HPV, that if the partner has ever had sex with anyone, they're likely to already have HPV. It's also in older people. It's, if there hasn't been a new partner, it could just be an old infection that has been reactivated, not a new infection. And it's important for everybody to realize that anytime you have a new sexual partner, even with one exposure, it's likely that both of you will have the same HPV. Encourage your partner to keep up with screenings too. We don't have any screening for oropharyngeal cancer. It's a little more common in men. There's nothing to do about it other than your dentist should be looking in your mouth and throat. Obviously, for people who have a cervix, they should be having regular, as recommended, cervical exams, and just generally regular wellness appointments. So who gets actually a colposcopy? Unfortunately, most abnormal results will require a colposcopy biopsy. So if you have an abnormal PAP or a normal PAP and HPV positivity at least a year apart, even with a normal PAP, then you get a colposcopy. The combinations of different results are sort of complicated, so you'd have to ask your doctor about your particular case. But luckily, one of my colleagues, Dr. Rebecca Perkins, developed a risk a calculator for patients, which is I put down here in the slide, and you can go in and put your own results in, and that will tell you whether you need colposcopy. But again, most people with an abnormal result do need the colposcopy. So what is the colposcopy? That's when a clinician looks at your cervix and vagina, and even sometimes your vulva, through a speculum. It's like a microscope, basically. They usually put vinegar on the cervix and vagina. The vinegar is literally vinegar. They might call it acetic acid. It may burn for a few minutes, but then it will evaporate. And the purpose of that is it dehydrates cells and makes the cells that are rapidly dividing appear white. Then we can take a biopsy of those areas to see if they are precancerous. Most of the time they won't be precancerous, but we can't tell just by looking. Even the best colposcopists cannot usually tell without a biopsy. So most of the time you'll have at least one biopsy with a colposcopy. So what to expect at a colposcopy, and will it hurt? So first of all, you will have a speculum placed into your vagina. It is usually a slightly wider speculum than usual so that the provider can see the vagina as well as the cervix. Remember that HPV can affect the cervix, vagina, vulva, and anus. So they want to get a good look at all of those areas. Most of the time, once you put that speculum in, people get used to it almost immediately. The provider will then put acetic acid or white vinegar on the cervix and vagina and look for areas that stain white. As I said, it does not mean the cells are precancerous, and so, but it does mean those areas to take biopsies. So biopsies are taken. Those biopsies are very small. I can't attest to every office, but in our office, they're about the size of the tip of a pencil. So they're really small. People always ask if we can numb the cervix. You cannot numb the cervix to get these biopsies for two reasons. One, the needle hurts as much as the biopsies usually. But second of all, once we infiltrate with the lidocaine, you can't really see the areas that appear white. So that makes it impossible to do an accurate colposcopy. Patients ask about pain, and basically patients have very different levels of pain tolerance. What I suggest to patients is that you take some ibuprofen before. And what we find is that distraction works really well. So, talk. I always chat with my patients while doing their colposcopies so that they are trying to think about something else. Some people will bring music with them. Some people meditate. In our office, and I'm sure in many offices, you could always bring someone at the head of the bed to support you. And in some cases, we'll prescribe Ativan if the patient feels particularly anxious. So results and next steps. So these are sort of questions that you should ask your provider, how long it takes to get the results. And that will vary by site. I mean, in our site, it takes about 2 weeks, but often in a more general OB/GYN site, we're a gynecology site, it may take a little bit longer. So find out from your provider how you're going to get the results and when to expect them. Make sure you find out if you'll also get the normal results back. The possible results after colposcopy are going to be a normal or low-grade lesion, which is of mild abnormality, and these are not precancerous, or a lesion that they call high-grade, which could be also called moderate or severe dysplasia, and those are considered precancerous. The next steps and the treatment does depend on several different things. It does depend on the results, but it also depends on your age and fertility concerns, as well as other medical history, such as whether you're immunosuppressed. If you are younger and have a small, slightly less serious lesion, it is possible that these will resolve spontaneously, and so you might be followed very closely with frequent colposcopy. But most people, if they have a high-grade lesion, will be treated. And then anybody who's had an abnormal screening history, whether or not you've had treatment, will not be a normal screening patient again. These now become surveillance patients. And after an abnormal result, you will go onto a regimen of either annual testing or every 3-year testing, depending on your prior results. And your provider will have to tell you that. There is an app that the provider can access to find out how frequently you need to come in. And there are national guidelines for that. And so the options are usually 6 months, sometimes after a high-grade lesion that needs to follow up, 1 year or 3 years. Once you've had a high-grade result in particular, you will need ongoing surveillance for at least 25 years. But even with the low-grade abnormalities, you will need closer surveillance at this point for an unknown period of time. Your prior history actually determines your current risk. So if you've had abnormal PAPs, abnormal HPV tests, biopsies, or treatments, that will affect your risk for developing cancer going further. A lot of times when people switch health providers or switch insurances, their results don't go with them. So my advice to you is to keep a record of every abnormal PAP and date you have it, every normal and abnormal HPV test, any biopsies you have in treatment, and keep an ongoing list for yourself. So anytime you see a new clinician, they will know what your results were, because that is definitely going to affect your risk and how often you need to be seen and tested. I'll give you a scary example of a patient who had a high-grade Pap smear and then went a Pap test and then had a colposcopy. The physician wasn't able to see anything abnormal, so asked her to come back in 6 months. But she switched healthcare systems and switched providers. And the next provider asked her the following question: when was your last PAP? She said 6 months ago. The provider didn't ask what the result was, and the patient didn't know she needed to share that. And so the provider assumed it was normal and said, come back in 5 years. When the patient came back, she had advanced cervical cancer. So that story made me really understand that we can't rely just on the provider, even a well-intentioned provider asking a question like, when was your last PAP? You have to own the fact that you want to always make sure that they know all your history of PAPs, if they were normal or not, and you keep a record of that as well. So other questions you can ask your doctor, and this comes from a set of flashcards from the American Cancer Society patient group. You can look at all the resources for patients from the American Cancer Society if you go to the National Cervical Cancer Roundtable from the American Cancer Society, and there are tons of patient-related resources up there. But these are some of the questions. How long to get my results? How will I learn about them? What does an abnormal test mean? And should I get the HPV vaccine? And finally, this varies a bit by state. Will my insurance pay? Thank you. I'm happy to answer any questions.
Sorry. Thank you so much. Now we'll start the Q&A. You can still submit questions in the Q&A section at the bottom of your screen. We will try to get through all of the submitted questions, but we might not be able to due to time constraints. Okay, so the first question we have: if I have had 2 normal Pap smears, would I go back to standard screening?
I'm presuming that means after an abnormal, that you've had a history of abnormal.
Yes, yes.
With a history of abnormal at this point in time, with the knowledge we have now, never goes back to normal screening.
Okay, okay.
It doesn't matter if you've had a history of abnormals, you never go back to standard screening. I want to say that again, because a lot of our providers don't know that. So
Okay.
you have to make sure to advocate for yourself. History of abnormal screening, even you've had 2 normals, it's possible, depending on what your prior result was, that you could go to every 3 years, but you're never going to every 5 years.
Okay, okay. What would be the PAP requirement in monogamous or non-sexually active patients?
It's completely the same, doesn't change.
Completely the same.
Sexual.
Okay. This is kind of a 2-part. Is there a different requirement if you're post chemo or radiation?
Well, it depends a little bit. Do you mean for cervical cancer or for other cancers? I don't know. I'll tell you
It says other.
Yeah.
I guess in this question, it's lung, breast, colon, etc.
Okay, yeah. So you would have the same normal screening unless. So the one thing I say to people is, if you're in the middle of chemo, you're immunosuppressed, so don't get your PAP, that year that you're getting your chemo. But
Okay.
otherwise, you would stay on the same regimen as
Okay.
other people. Now, if you have a history of cervical, vaginal, or vulvar cancer, you're going to be on annual testing.
Okay. Okay. So if you are on, so you mentioned, if you're on treatment, maybe hold off that year. Could chemo or radiation affect your PAP results?
Well, yes, I mean, chemo and radiation are going to suppress your immune system. So I've seen transient abnormal results on the year of the chemo that aren't really going to, aren't really relevant because it means your immune system is suppressed. The HPV that you've had for years pops up its ugly head for a year and then it goes away. So
Mhm.
I would say stay away from the testing on the year you're on chemo, because then an old HPV infection can appear positive, but probably isn't really putting you at risk. So wait till you're done with chemo.
Okay. Okay. Can you have an abnormal pap smear multiple times?
Oh, unfortunately, my entire practice is people who have abnormal paps. So this is a really important thing. If you have persistent abnormal paps, you need very aggressive evaluation. So the longer you have abnormal paps, the longer you have abnormal HPV, the higher risk you are for developing cervical cancer and occasionally vaginal and vulvar cancer. So when I see patients just like that who've had multiple abnormal paps, and maybe the reason hasn't been found, and we evaluate in addition to the cervix, the vagina and vulva. Sometimes we have to do diagnostic procedures that are a little more aggressive to make sure we haven't missed anything. But yes, many women have multiple abnormal paps. And I shouldn't say women, I should say people with a cervix. So it's whether you have a cervix is the defining factor.
Okay. Okay. How often should women over 60 receive pap smears?
So that depends on your history. So if you have a history of abnormals, you're going to need more frequent. And if you're all normal, then you continue to need to have testing. If it's by HPV related test, co-test, or HPV alone, every 5 years, if all normal, and if PAP alone, every 3 years, if all normal. And you don't necessarily have to stop at 65. If you have had abnormals in the past, you're not going to stop at 65. If you're immunosuppressed, and that includes solid organ transplant, HIV, rheumatoid arthritis, inflammatory bowel disease, a lot of diseases that you're on chronic immunosuppressive medications, you would not stop at 65. And then women who are otherwise healthy and have a long life expectancy, like, 30 more years, they probably shouldn't stop at 65 either. I mean, the decision to stop at 65 is, it's based on old data. And so I would advocate for people to consider screening beyond 65 if appropriate, if they have a reasonable life expectancy.
Okay. Okay. That was my next question. So what is the standard protocol for atypical pap results without HPV?
So ascus HPV negative in a patient who's always had normal results may well be not really an abnormal. And so if somebody has always had normal results and adequate screening, so they've had all their tests forever and they've all been normal and they've had enough of them, meaning every 3 years if it's PAP alone and every 5 years if it's PAP and HPV, then one single ascus HPV negative is probably nothing. Sometimes we'll check some, sexually transmitted disease testing to see if there's some infection causing the ascus. Because remember what I told you, that the ascus is just the pathologist saying, oh, this looks a little funny. It's not necessarily cancer related. So if the HPV is negative, we don't do much. So that's sort of treated as a normal result.
Okay. Okay. Should you tell your partner you have HPV?
Well, I alluded to that before. I mean, 80% of people have something. If it's a male partner, they literally don't know they have it because we don't test the male. There's no test for men. So they walk around, 80% of them carrying a virus. They know nothing. They don't know they have. They're giving it around to everyone they have sex with. I'm just being honest. So that I don't know why, if it's a female, then walking into this relationship, she has to make herself feel bad by implying she's given a sexually transmitted disease to the partner that has very little risk from it and has probably been infecting other people. So I personally don't necessarily think it's an STD that you have to share. Now, that is not to say you shouldn't share all STDs. Most of the rest of them do have an impact on the partner and can be treated and prevented, and they should be. But this is one that has very little there's nothing to do about it. And the only way to avoid is to literally not have any intimate contact. Doesn't even require intercourse. So I'm not telling my patients they have to tell everybody they know.
Yeah. Only I guess 2 quick questions we have left. What causes an abnormal pap smear in the absence of HPV?
Well, the only other situation I told you would be an infection. So sometimes the HPV test might be negative, but that doesn't really mean you don't have HPV. So I mean, if you have an abnormal pap that's more than an ascus, even if the HPV is negative, I mean, you've probably had HPV. There's really nothing else that causes it.
Right.
Oh, actually, I shouldn't say that. There is one other possible thing, which is you could have abnormality in your uterus, glandular abnormality in your uterus, and that would be concerning for endometrial cancer, a different cancer, and that's not HPV related. So yeah, that would be non-HPV related, but it also wouldn't be, you would need evaluation.
Okay, I see. Well, that's our time today. Thank you, Dr. Feldman, for such an informative program, and thanks to all of you for submitting your questions and participating in the Q&A. Make sure you check out SHARE's website for upcoming educational programs and support groups, including our gala, the second helping of life being held in New York on September 21st. And don't forget to follow us on social media as well. Please take a moment to fill out the survey at the end of the webinar. The survey will show up in the browser when the webinar ends, and the link will also follow in the email. All surveys are anonymous. This concludes the webinar. Thank you.
Thank you.
Bye-bye.